Hello everyone, and welcome to our first module on arthritis. Arthritis refers to joint inflammation and swelling, and there are many different types of arthritis. In this video, we're going to focus on osteoarthritis and rheumatoid arthritis, which are two very common forms, and then in another video, I'll talk about other forms of arthritis. You should also be aware of one general point, and that's that the diagnosis of the cause of arthritis can involve a procedure called arthrocentesis. This is a picture of what it looks like on the screen here. It involves using a needle and syringe to aspirate some synovial fluid, and this is used for diagnosis of the cause of arthritis in some cases. It can also be done as a therapeutic procedure if someone has a large joint effusion. There are a number of different ways to classify arthritis. One is in terms of non-inflammatory versus inflammatory arthritis. Non-inflammatory arthritis is often called degenerative arthritis, and usually this is caused by osteoarthritis, which we'll talk about in a second. Patients with non-inflammatory arthritis have joint pain, but they usually don't have warmth or swelling. If you aspirate the synovial fluid in patients with non-inflammatory arthritis, the white blood cell count is usually low. If you look at this table I've placed on the screen here, normally the synovial fluid white blood cell count is less than 200. In patients with non-inflammatory arthritis like osteoarthritis, the white blood cell count is usually in the range of 200 to 2000, which is relatively low. And then in patients who have inflammatory arthritis, the white blood cell count gets very high, often over 2000. You should also be aware that many patients with arthritis have morning stiffness, and the duration of morning stiffness can be an important clue for diagnosis. In patients who have non-inflammatory arthritis like osteoarthritis, the morning stiffness is usually very brief, less than 30 minutes or so. Now, in inflammatory arthritis, the joints are usually warm and swollen. There's an elevated white blood cell count, like we talked about on this table. And then the morning stiffness in inflammatory arthritis is usually prolonged. It usually lasts more than 30 minutes. You can also classify arthritis in terms of the number of joints involved. If there's only one joint involved, that's called monoarthritis. If 2 to 4 are involved, that's oligoarthritis. And when patients have more than 5 joints with arthritis, that's called polyarthritis. Okay, so now let's talk about osteoarthritis. So osteoarthritis is degeneration of synovial joints. And synovial joints are joints that look like this drawing on the screen here. They have a synovial cavity between the two joints filled with fluid, and this helps the bones to slide along one another. And there are lots of examples of synovial joints in the body. This includes the joints of the hands, also the knees and the hips. In terms of pathophysiology, there's a couple of things you should know about osteoarthritis. First of all, one of the major features is hyaline cartilage breakdown. So hyaline cartilage is this cartilage that surrounds the synovial joint space, and it provides a smooth surface so the bones can glide along one another, and that breaks down in patients who have osteoarthritis. The pathophysiology of osteoarthritis is complex, but one thing that happens is the bone along the joint space starts to hypertrophy. And this can cause sclerosis of subchondral bone, which is bone beneath the chondral membrane. I'll show you a picture of this. You can see it on X-ray in patients with osteoarthritis. Hypertrophy of bone can also lead to bone spurs or osteophytes, which you can also see on X-ray, and we'll see a picture of this later as well. And then finally, when the cartilage breaks down and the bone hypertrophies, the joint space can narrow, and eventually patients can have bone on bone in a synovial joint. And then, as I mentioned earlier, in osteoarthritis, there's minimal inflammation of the synovial fluid, and that's because this is non-inflammatory osteoarthritis. In terms of clinical features, osteoarthritis leads to an insidious or slow onset of joint pain. There are pain fibers in the bones and they get irritated by movement, so patients will complain of a deep, dull ache. It's often worsened by activity because that causes the bone to rub against the joint space, and it's improved by rest. Patients with osteoarthritis may complain of joint stiffness, often in the morning or after inactivity. But importantly, as I mentioned before, the joint stiffness usually lasts less than 30 minutes. When it lasts more than 30 minutes, that suggests another diagnosis other than osteoarthritis. And then lastly, joints can develop restricted motion from osteoarthritis. This is because the bones can enlarge and this limits the movement. Osteoarthritis can affect any synovial joint, but some of the classic joints are the weight-bearing joints. So commonly, osteoarthritis develops in the hips and the knees. It can also develop in the cervical spine or the lumbar spine. You can also see it in the hands. All these places shown in the skeleton are where osteoarthritis commonly occurs. And osteoarthritis can be monoarticular or polyarticular. It often starts as monoarticular symptoms in one joint that's the most affected joint, but over time, patients can have multiple different joints involved. Some of the important risk factors are shown in this slide. OA is a disease of advanced age. 80% of patients are over 55. Obesity is also an important modifiable risk factor, especially for osteoarthritis of the knees and hips. Those are weight-bearing joints, and obesity increases the risk of OA in those joints. And then any type of joint trauma makes osteoarthritis more likely. This could be someone who had a major trauma to a joint. It also can be someone who has repeated microtrauma over time from repetitive use of a joint. The diagnosis is clinical. If a patient has classic features, you don't need to order any tests and you can begin treatment. But there are supportive findings that you can see on X-ray. These include all of these things right here, and I'll show you a picture of these in the next few slides. An arthrocentesis is usually not done, but if it is done, there will be a low white blood cell count in the synovial fluid because, as we talked about earlier, this is a non-inflammatory form of arthritis. And then lastly, all blood tests are normal. There are no blood test abnormalities expected in OA. So here's an example of joint space narrowing. This is what a normal knee joint should look like. And then over here on the other side, we have a joint space that's severely narrowed, especially on this side here. That's evidence of osteoarthritis. Subchondral sclerosis refers to thickening of the subchondral bone, which is the bone just below the joint space. This happens because there's increased collagen deposition and abnormal mineralization as part of the pathophysiology of OA. So you can see this white stripe here just below the joint space. That's evidence of subchondral sclerosis. And then osteophytes or bone spurs occur due to thickening of subchondral bone at the margins of the joint. This is one right here. I've zoomed in so you can see it over here on the side. This often happens at insertion points of tendons or ligaments in patients who have osteoarthritis. And then finally, a subchondral cyst is a fluid-filled sac that develops below the joint space. This happens when patients develop cracks in the bones and synovial fluid accumulates in a fluid-filled sac. Okay, now let's talk about some specific joints that are commonly involved in osteoarthritis, and we'll start by talking about the knees. So osteoarthritis often involves both knees, and that's because these are weight-bearing joints and they tend to both degenerate due to holding up a person's weight. You should also know that there's more weight-bearing on the medial side of the knee joint, so osteoarthritis is often asymmetric with joint space narrowing on the medial side. If you look at this X-ray on the screen, you can see that the joint space on this side is much more narrow compared to that side. That's asymmetric narrowing, a common feature of osteoarthritis of the knee. Osteoarthritis of the hip often causes groin, buttock, or thigh pain. You should be aware that patients won't always complain of pain at the hip. They may complain of pain in these areas here. In addition, on exam, there's a reduced range of motion of the hip joint, and sometimes you can feel crepitus, which is a cracking or popping sensation over the joint as it's moved. And in contrast to the knees, osteoarthritis of the hip is often unilateral and affects only one side. In the hands, osteoarthritis classically involves the distal interphalangeal or DIP joints, and it's very high yield to remember this, and that's because in rheumatoid arthritis, the DIP joints are almost always spared. We'll talk about rheumatoid arthritis later in this video, but in a board question, if the DIP joint is involved, that makes osteoarthritis much more likely than rheumatoid arthritis. You can also have involvement of the PIP joints, but not the MCP joint, and then the first CMC joint, which is the joint at the base of the thumb, is also a classic location for osteoarthritis. Nodal osteoarthritis occurs in patients who have osteoarthritis of the interphalangeal joints of the hands. Patients can develop swelling or nodes in these joints. When the swelling or nodes occur in the distal joints, they're called Heberden's nodes, and when they occur in the proximal joints, they're called Bouchard's nodes. And these nodes develop from bony overgrowth and osteophytes. What happens is patients who have long-standing OA of the hands, over years, the joints can actually become less painful and inflammatory signs can subside, but these swellings or nodes will remain. And they're particularly common in the index and middle fingers in patients who have OA of the hands. In terms of treatment, what they're going to want you to know for your boards about osteoarthritis is that the initial treatment is usually not drug therapy. Usually patients are advised to lose weight, to get exercise, and sometimes to go for physical therapy. In particular, exercise and physical therapy can maintain range of motion of the joints and improve strength, and these things can lead to symptom relief. When drug therapy is used for severe or refractory symptoms, it's often with NSAIDs. There are topical and oral NSAIDs that can be used, and then beyond NSAIDs, there are other drugs that are used for OA. Okay, moving on, now let's talk about rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder that leads to inflammation of the synovium. So the synovium is a thin layer of tissue just a few cells thick, and it lines the synovial cavities, and it secretes hyaluronic acid, which is a substance that lubricates the joint space. Because RA is an autoimmune condition, it's a systemic disease and it does have many extra-articular or non-joint complications, and we'll talk about those in a minute. Like many autoimmune diseases, it's more common in women. The usual age of onset is 20 to 40 years, and the disease course can wax and wane with flares over time as people have rheumatoid arthritis. In terms of clinical features, RA usually leads to symmetric joint inflammation, and this is an important point. Because it's an autoimmune disease, it tends to affect the joints on both sides of the body and present as symmetric joint symptoms. The symptoms have a gradual onset. Patients complain of joint pain, stiffness, and swelling. Classically, RA causes prolonged morning stiffness, so patients with RA will complain of joint stiffness in the morning. Often that lasts more than 1 hour after rising, and that gets better with use. And remember how we talked about that osteoarthritis can have morning stiffness, but it usually lasts less than 30 minutes. And then because this is an autoimmune condition, RA can lead to systemic symptoms, so patients can have fever or fatigue or weight loss associated with their joint pain. Rheumatoid arthritis most often involves the wrist or the hands, and classically in the hands it affects the MCP and PIP joints. These joints are often tender to the touch in patients with rheumatoid arthritis. Importantly though, as I mentioned earlier, the DIP joints, the distal joints of the hand, are usually spared in rheumatoid arthritis, and that's in contrast to osteoarthritis where the DIP joints are usually involved. You should also know that spine disease of the lumbar spine is very rare in rheumatoid arthritis, and this is also in contrast with osteoarthritis where the lumbar spine is a classic location. In long-standing untreated rheumatoid arthritis, the bones can erode and deviate, and there are some classic findings that occur clinically when this happens. One is called ulnar deviation. So in ulnar deviation, there's swelling of the MCP joints of the hand, and this causes the fingers to deviate over toward the side of the wrist with the ulna bone. Another finding you can see is called the swan neck deformity. This occurs when there's hyperextension of the PIP joints, like I'm circling here, and then a flexed DIP joint, and this gives the appearance of a swan's neck, like you can see in this picture. The spine is usually spared in rheumatoid arthritis except for one area of the cervical region, usually around C1 to C2, and it's high yield to know about this for your board exams. This is called the atlantoaxial joint, and in long-standing rheumatoid arthritis it can become involved, and this can lead to the development of neck pain and stiffness. It can also in rare cases lead to a serious complication called cervical subluxation. This is a potentially life-threatening spinal cord compression that can require surgical treatment, and it happens in patients who have rheumatoid arthritis of this cervical region. Now we'll talk in a minute about DMARD therapy or disease-modifying therapy for rheumatoid arthritis, but this DMARD therapy limits the risk of cervical subluxation and limits cervical region disease. But because of the possibility of disease of the joints in the neck, a cervical spine x-ray is often done before surgery in patients who have rheumatoid arthritis. And that's because you want to know if they have disease of the neck, because if it's present, there's a risk of neurologic injury when the patient is intubated and the anesthesiologist has to manipulate the spine. Another clinical feature of RA you should know about is the development of a Baker's cyst or a popliteal cyst. This is a cyst that develops at the back of the knee, caused by swelling of the gastrocnemius semimembranous bursa. This is a fluid-filled sac, a synovium-lined sac filled with fluid at the back of the knee that's continuous with the joint space, and it can swell and develop into a cyst. And Baker's cysts commonly develop in patients who have either osteoarthritis or rheumatoid arthritis of the knee. Often it's simply an asymptomatic bulge behind the knee, but sometimes it can rupture, and when this happens, this leads to symptoms that are very similar to a deep vein thrombosis. Patients will complain of posterior knee pain, swelling, and there can be ecchymosis. So in a patient who has symptoms of a DVT, but the ultrasound shows no clot, if the patient has rheumatoid arthritis, one thing you should think about is that could be a ruptured Baker's cyst. Usually Baker's cysts are a clinical diagnosis, but as I just said, in cases where patients have pain, you may need to rule out a DVT with an ultrasound. Okay, there are lots of non-joint or extra-articular features of rheumatoid arthritis, but I'll go through some of the important ones in the next few slides. First of all, patients with RA can develop serositis, which is inflammation of serosal surfaces, like the pleura or the pericardium. So this can lead to pleuritis and pleural effusion. It can also lead to pericarditis and pericardial effusion. Parenchymal lung disease, which is disease of the lung tissue, is common in RA. Patients can develop interstitial fibrosis and also pulmonary nodules. Carpal tunnel syndrome is also more common in patients with RA, and because this is an inflammatory disease, it can lead to anemia of chronic disease. Rheumatoid nodules are palpable nodules, and they're very common in patients with rheumatoid arthritis. They occur in up to 35% of patients in some series. If a patient has one of these nodules, it's pathognomonic for rheumatoid arthritis, and it clinches the diagnosis. They're common at the elbow. This is a picture of one at the elbow, although they can occur anywhere, and usually they don't require any specific treatment. They're just a feature of RA. Patients can develop eye inflammation in RA, like episcleritis or scleritis, so they can develop red eyes or eye pain or discharge. And then Sjogren's syndrome, which I talk about in another video, which is a disorder of salivary glands. It leads to dry mouth, and this is more common in patients who have RA. You should also be aware that osteoporosis is accelerated by rheumatoid arthritis. In addition to being accelerated by the disease itself, it's often worsened by steroid treatment, which is sometimes necessary in RA. So patients who have RA have an increased risk of a major fracture and an increased risk of hip fractures from osteoporosis. Let's talk about the diagnosis of rheumatoid arthritis. So generally, to meet criteria for rheumatoid arthritis, patients need to have an inflammatory arthritis of 3 or more joints that last more than 6 weeks. In addition to this clinical feature, there are some blood tests that support the diagnosis. The first is measurement of a rheumatoid factor. This is positive in 70 to 80% of patients with RA. Unfortunately, it has a low specificity, so it's elevated in some normal patients and other conditions. So just because a patient has a positive rheumatoid factor doesn't mean they necessarily have rheumatoid arthritis. You can also measure antibodies to citrullinated peptides, or ACPAs. These antibodies are more specific for the diagnosis of RA. And then lastly, because this is an inflammatory condition, acute phase reactants are usually positive, so patients will have an elevated CRP or erythrocyte sedimentation rate. The mainstay of treating rheumatoid arthritis is with disease-modifying anti-rheumatic drugs, or DMARDs. These drugs are called disease-modifying because they've been shown to protect joints from destruction over time. They provide long-term reduction in disease progression and complications. Now, they have a slow onset of effect over weeks, so they aren't useful in patients with acute symptomatic joints from RA, and they're usually given as oral drugs. And we'll talk about specific DMARDs in a minute. In addition to DMARDs, pain control is important when patients first present with painful swollen joints. This is used as bridging therapy until the DMARDs take effect. So patients are often given NSAIDs. This is the drug of choice for pain control in patients with a flare of rheumatoid arthritis and a painful swollen joint. Corticosteroids are sometimes used if NSAIDs are inadequate for pain control. And in patients who have RA, when they have a symptom flare, often they're given a short-term course of steroid treatment to minimize the joint swelling. In terms of DMARDs, what you want to know for your boards is that methotrexate is the best initial DMARD. This is the classic treatment for rheumatoid arthritis. It's also high yield for your boards to know some of the side effects of methotrexate because there are a number of these. First of all, methotrexate inhibits folate metabolism, so it can suppress the bone marrow. So the CBC is always monitored in patients taking this drug. Sometimes methotrexate is co-administered with folic acid because this will replenish folate in the body and limit the bone marrow suppression. Methotrexate can also cause hepatotoxicity, so LFTs are monitored in patients on this drug. It can also cause stomatitis, which are painful sores in the mouth. And then lastly, methotrexate is primarily eliminated by the kidneys, so the creatinine is usually monitored. And then beyond methotrexate, all of these drugs are also sometimes used as DMARDs in patients who can't take methotrexate or where methotrexate is ineffective. Other treatments that can be used for rheumatoid arthritis are biologics. Biologics are antibody-based treatments, and they're given as an infusion or an injection. And these drugs are used when methotrexate does not control the disease. Some of the biologics that are used are anti-TNF-alpha therapies. These are antibodies that target TNF-alpha. These are drugs like Intaracept or infliximab. And then there are also non-TNF biologics like these drugs I've listed here. Importantly, patients who are going to receive biologics are usually screened before treatment for latent tuberculosis, and that's because latent TB needs to be identified and treated before therapy, otherwise the patient can have a flare of their tuberculosis. Patients are also often screened for hepatitis B and C as well. You should be aware that long-term complications of rheumatoid arthritis include an increased risk of coronary disease. This is the leading cause of mortality. Because this is an autoimmune disease, it can lead to inflammation of blood vessels, and that can lead to plaque in the coronary arteries and coronary disease. Patients with RA can also develop secondary amyloidosis, which I talk about in videos in the hematology section. And then finally, I'll finish with one slide on Felty syndrome, which is a very rare complication of rheumatoid arthritis. Felty syndrome is a syndrome of splenomegaly and neutropenia that occurs in a patient with rheumatoid arthritis. So because these patients have neutropenia, they will have a low white count on blood testing. Also because of neutropenia, they have an increased risk for bacterial infections. And then they can present with abdominal pain, and that's from an enlarged spleen. Classically, this occurs many years after the onset of RA, and it's usually in a patient who has severe rheumatoid arthritis, usually patients with evidence of joint deformity or extra-articular disease. And Felty syndrome improves when you treat the rheumatoid arthritis, and the most important thing to know about this for your boards is just what it is so that you can recognize it in a description. And that concludes our first module on arthritis.